Welcome to the Health Deli, your local stop for a fresh take on community health topics. Come on in, grab a number, and let the guys behind the counter, Mark, Ben, and Mike, tell you about today's specials.
Good day. Welcome to the Deli. It's another beautiful day up here in the Health Deli studios on the campus of Ferris State University in the television and digital media production studios. Unfortunately, I am joined here by Andrew and Natalie. Hi, guys. How are you doing?
Hello.
Hi.
Great to have you here. So today I'm going to be talking...
So what are we, chopped liver?
Yeah.
I'd like to say spam.
Is this the Mike and himself show or what?
No, we're here.
True.
I've got
Andrew and Natalie. I honestly don't need you two anymore.
I'm actually surprised. I'm surprised that our microphones aren't turned off.
Natalie, I said turn them off, man. Okay. All right. So Ben and Mark are here as well.
Top of the morning to you, everybody.
Nice seeing
When did you become Irish? I thought you always liked the bonjour stuff. We thought you were French for the longest time.
There's French-Irish people.
Mark, how are you doing?
I'm great. Just great.
Just great.
This episode's off to a great start. Can I just say that?
Nope, you may not. All right. Well, before we jump into things, what have you guys been working on? You know, we're well into season 3, kind of actually at the tail end, but we still got a few good specials are coming. What's on your plate?
So I've been teasing it for a couple episodes now, but I actually split it into 2 episodes. One, unknown or kind of little known body parts and what they do, and then unknown or little known bodily functions and their purpose. So I think those are gonna be fun episodes. So
I am not going to sit next to you.
It'll be great. Yeah. I'll sit next to you. It'll be fine. I can't smell anything because of my allergies.
perfect.
Yeah. So I'm actually doing probably a follow-up episode to the allergy episode that we just kind of put out. Maybe talking a little bit about like allergy shots, immunotherapy, some of those kinds of things. Maybe the people that are suffering a little bit more from allergies than just your like run-of-the-mill seasonal allergy. So I think that can be pretty interesting.
Excellent. No, that does sound good. I'm surprised you came up with that. Oh, wait, that was Mark and I that came up with that idea.
Yeah, I'm bringing my neti pot in.
Good job, Mark. No.
What?
Neti pot?
Yeah,
isn't that where you put water in your head and drain things out?
Nose, yeah. Put it
Isn't
in
that
your
called?
nose.
Isn't that called drowning?
No. Waterboarding is another term, but
For neti pot.
Can I take a second and just say that was the most awkward fist bump I've ever seen in my entire life?
Well, we had to pause when he brought up neti pot.
yeah, he didn't want to bump the fist after neti pot.
yeah,
He
it
took
was-
the fist bump.
What are we talking about today, Mike?
Well, today, before we get in for the topic of the day, we've decided, and this is we just kind of talking, that we were going to play the Have the Layperson Say Medical Terms episode. And so, you know, this might be a little cheating because I would like to give it to them in print beforehand so they have to try to pronounce it. But I want to see if Andrew and Natalie can pronounce the word pheochromocytoma.
Pheochromocytosis.
That was like 60% of the way there.
Not bad. It started out great.
What was it again?
Nope, you get it once.
Oh, pheochromocytoma.
Woo!
Very good. She could be in medicine.
That was
Natalie has some medical training.
All right, rock on.
I've taken a medical terminologies class before.
Nice. And so now
that
for
explains
Andrew's homework for the rest of the episode is he has to look up the term pheochromocytoma and tell us what it is.
And you're not going to tell them how to spell it,
Nope.
I'm guessing. Okay.
Not going to. While Andrew's doing that, I see him over there doing syllables. Now he's clapping his hands.
F, E.
Okay.
I love how Google interprets your words.
So today, we're going to talk about antibiotics.
Ooh, my
Something
favorite.
kind of near and dear to our heart. But what I really want to talk about is avoiding antibiotics.
So why would I want to avoid antibiotics, Mike?
Because we know, Ben, that as good antibiotic stewards, that we don't want to overuse antibiotics and we don't want to use them when they're not necessary, because when this happens, we can lead to resistance. We can have adverse events. We have increased medical costs and so forth. And so in the hospital, a lot of patients get infections. We have to give them antibiotics to treat those infections. On the outpatient side, a lot of the times we're not as good at diagnosing people with a true infection, and we give antibiotics sometimes when they're not warranted.
Yeah, and I just want to highlight that we say that, but that's because diagnosing things is really hard, right? Like we're not trying to knock physicians, PAs, NPs, those hard workers that are doing that stuff. But the human body is really complex, right? This is a difficult thing to do. And so there might be a chance where maybe it's an infection, maybe it's something else. It's kind of like a gray area. So I just want to kind of highlight that it's very complicated.
And then people get an antibiotic, and it reinforces the fact that that antibiotic helped them when maybe the disease was self-limiting anyway.
Yeah.
So you're going to get better whether or not you got it. But once you get that antibiotic and you feel better in 3 days, you're like, ooh, I need that antibiotic.
Right.
Well, and that's really the thing. I mean, when you think about it, our body is a great organ that will clear invaders. And a lot of the times our body can handle infections, whether they're viral or bacterial, and it can probably clear 60 to 70% of invading pathogens on its own. But we give antibiotics to help the process along, help reduce some complications, and maybe in those cases where the body's not able to fight it off, to kill the bacteria, the virus, to help the body get better. But like you said, people get better. And so even if they didn't need the antibiotic, they associate, hey, I got better because I started the antibiotic. But again, overusing antibiotics, especially in the outpatient setting, can be a problem. And one of the things that it causes is antibiotic-resistant bacteria, because the more you expose a bacterium to an antibiotic, the more likely it's going to develop some sort of resistance to it. And it's been estimated that there's more than 2.8 million antibiotic-resistant infections that occur in the United States every year, and that almost 40,000 people die every year because they're infected with a drug-resistant pathogen. And it's been estimated that by the year 2050, infection-related mortality is going to surpass mortality that's been associated with cancer.
Which is a wild thing to think about from my perspective. Because, I mean, right now, pretty much we can treat everything, right? Like we have antibiotics that can treat everything. But if we get resistance, it's going to just skyrocket, right?
Exactly. And, the other thing with that is when people get resistant bacteria or resistant pathogens, then we're not able to use our less expensive first-line antibiotics a lot of the time, so it drives up costs. And every year, it costs us over $20 billion with a B to treat these antibiotic-resistant pathogens. And, again, getting back to this idea that hey, I'm feeling sick and I need an antibiotic in the outpatient. Antibiotics are not innocuous. They're associated with a lot of bad things when used inappropriately. In fact, 1 out of every 5 emergency department visit for a medication-related event is caused by an antibiotic. And about 56% of drug-related visits to the emergency room in kids is related to an antibiotic. And that's significant, for those. And then on top of that, we know that when you kill off your good bacteria, so I give Ben an antibiotic, it not only targets the bacteria that I wanted to, let's say he had a lung infection, but that antibiotic goes everywhere in his body and it kills off those bacteria too, including those maybe in his, oral cavity or his mouth or in his GI tract. And so sometimes we can have overgrowth of less friendly bacteria like Clostridioides difficile, which causes severe diarrhea, C. diff. Causes significant mortality and morbidity.
Yeah, and that's something that I always find really interesting is that our world and our body is not sterile, right? There are bacteria, there are viruses just all over the place on us. And it's impossible to get rid of all of it. But not all of them are damaging us, right? And so when you give an antibiotic, kill all of the good bacteria that's living in our body, then bad stuff like C. diff can kind of take over.
Exactly. So we got to be careful with that. And to help with this, this judicious use of antibiotics, we've developed these antibiotic stewardship programs in hospitals and in clinics and stuff like that to help clinicians optimize drug therapy. So use them at the appropriate dose in the appropriate patients for the appropriate duration of time to optimize therapy and minimize side effects. And so that's been really effective, throughout the years. Unfortunately, historically, the past 30, 40 years, the majority of our stewardship efforts have focused on the inpatient setting. So if you're admitted to the hospital, you might have an ID physician or an ID pharmacist come evaluate you if you're getting an antibiotic just to make sure that you're, being treated appropriately. And we focused on that. Why? Why do we focus on the inpatient setting?
So go ahead, Mark.
I'm just going to say because we could. Where the outpatient setting is kind of like we see you for 2 or 3 minutes, maybe only, or 5 minutes, and then you're gone, right?
Yep.
So we have kind of one shot to make a guess. Whereas in a hospital, you're seeing the patient a lot more often.
So Mark's exactly right. We started on the inpatient setting because that's where we had the resources, that's where we had the people, that's where we had the lab results. So it was easy to focus on that because we could see what was going on and do something. And then we could track what we did. Hey, did the patient die because they used to be right there in that bed, or they get discharged or whatever. So it was very easy. So yay, we win.
Yeah.
We did great things in that. However,
But
yes. Unfortunately, we know that only about 20% of the antibiotics that are used in humans are used on the inpatient setting. So that means there's 80% that are being used in the outpatient setting, where essentially nobody's been watching for the last hundreds of years that we've been using antibiotics.
And just in my career, which isn't that long, I've noticed a lot more, how should I say, more potent, I guess would be a word, for antibiotics available orally. So there are, more antibiotics available now. And, just with the stroke of a pen, figuratively, you could order any of those oral agents for outpatients. So.
yeah, it's a lot easier to give antibiotics in the outpatient setting, and it's easy to give really broad spectrum antibiotics too.
Yeah.
So things like levofloxacin or Levaquin cover a lot of bacteria. They kill a lot of stuff, and you can give that orally. And so, yeah, a physician could just write that for somebody, which is wild.
Yeah, exactly. And, that becomes problematic. Not only are those drugs there and available, but also take into effect that we have an aging population, so more susceptible to some of the side effects. And there's also an impetus to keep people out of hospitals. You only want really sick people in the hospitals. So, there's more likely that you're going to, keep going to the doctor and maybe need an antibiotic.
Yeah, because we've talked about the cost of healthcare a couple of times in different episodes, and that's one of the ways we try to decrease that, right? Because it's expensive to stay in the hospital. So we want to try and keep people out of the hospital, which might mean a physician might give somebody an antibiotic where they're kind of up in the air on whether they need it or not.
And physicians are under a lot of pressure to prescribe. They're under pressure from payers, because to keep people out of health systems, they're under pressure from patients who want to get better as quickly as possible. So I don't want to be just pointing a finger at physicians.
Oh, for sure.
That's one thing that I want to tease out, because there's this belief in medicine that when a patient's sick, they come to us for a drug or an antibiotic. You know what? When I'm sick, I don't go to the doctor for a medicine. I go to the doctor because I want an answer and I want to feel better. Okay? Unfortunately, the way that medicine is structured right now is, you mentioned, they're under a lot of pressure to see lots of patients quickly. And so sometimes it's easier just to prescribe something than to have that discussion and fully work somebody up. So there's, the health system is a little broken from that perspective.
Yeah, it certainly is. Because I don't know if you plan on getting into this too much, Mike, but there is literature out there looking at the way you communicate your recommendations. And so physicians can say things in different ways and be more personable than even if you're not giving an antibiotic. Patients will
seriously,
still be
would
satisfied.
I ever talk about being more personable?
No, which is why I wanted to bring it up.
So yeah, it's not happening during this.
I was being
Shut
polite
up,
by
shut
asking
up, Ben.
you.
Shut up.
Thanks for that, Ben.
Quit interrupting my podcast.
For bringing
hey,
that up.
Natalie, Andrew, how you guys doing over there? Do you guys want to sit at the big people's table? Because
Maybe-
I'd like to get rid of these guys.
Maybe we should have an intervention episode where we hijack it and have an intervention.
All right, this is where
That's
I'm
actually this
this is
episode.
where I'm actually going to share some more knowledge with you guys, because I feel like you guys need it. All right, so just some factoids here about antibiotic use in the outpatient setting.
Okay.
Of all the antibiotics that are prescribed in the outpatient setting, do you know that about 30% of those are just downright not needed?
I did know that, because if you had asked me, I would have said 30%.
Okay, because you're a moron. But you would have been correct in this case.
In that case, I would have been correct.
But so you go, so what are they being used for? Well, unfortunately, again, sometimes we can't distinguish between bacteria and viruses, or bacteria and some other things like a chronic cough or an exacerbation of bronchitis. And so people just prescribe antibiotics. And with that, every doctor, of all the doctor's visits that go on in the United States, about 13% of those result in an antibiotic prescription. That's about 154 million episodes of antibiotic prescriptions every year.
That is, eye-opening to me.
Well,
I did
here's-
not realize that.
Here's another way to put it into perspective. Out of every 1,000 people in the United States, 613 oral antibiotics are prescribed every year.
Wow. But-
So
So I'm guessing multiple people are getting more than one antibiotic
Yes.
probably, but still
Yes.
that's a crazy statistic to
It,
think about.
it is. And that varies from area of the country. And there's some areas, some states where you see that up in the 800s. And so it's really, really problematic. And when you ask about what the heck are these antibiotics being used for, the most common causes that bring people into the doctor looking for antibiotics are respiratory infections. Things like acute sinusitis, bronchitis. And interestingly enough, those aren't bacterial.
Yep.
Those are all viral infections. But again, a lot of people come away with antibiotics. Also, sore throats. Okay. Sore throat, first thing you think about is like strep throat, need an antibiotic. Okay, guess what? Even in kids who are the highest rate of having bacterial causing this acute sore throat, only about 30% of those cases are caused by bacteria.
Yeah.
And in adults, it's less than 15%. Yet we see upwards of 50, 60, 70% of patients with that acute sore throat coming away with prescriptions for antibiotics.
Because there is that expectation.
Because there's that expectation, and because there's maybe a lack of trust or a lack of time to do the appropriate diagnostics.
Yeah, and I think that is a big piece of it that we've harped on a couple times is that time expectation, right? Where you only have a couple minutes to see your patient. And you're like, I don't want to, maybe I missed something, right? Like I didn't have time to do all the full evaluation I wanted to. It's a really complicated issue, and there's a lot of different factors.
Or simply the patient will say, if I don't get an antibiotic, I'm just going to go to another doctor.
Right, I'm going to go to the urgent care across the street.
Well, and
or whatever.
unfortunately or fortunately, that's where Ben's point comes up about how you present that recommendation. If you just tell them, no, you don't have a bacterial infection, no antibiotic, yeah, they're going to go somewhere else. Or if you don't need an antibiotic, but if you have the ability to take the time and say, hey, we've determined that it's not a bacterial cause, so antibiotics are not going to do you any good. It's likely to be virus or whatever, so we do these other things.
And then continue that conversation. I don't want to give you an antibiotic because it might cause diarrhea, and it's going to cause resistance, and it's going to cause all these other things.
Yeah,
and then side effects. They're not that great, really.
Right. And then to Mike's point about patients just want to feel better, right? So if you're like, this medication that's not an antibiotic, maybe it's a decongestant or whatever, it's going to help you feel better. So I'm going to give you that instead.
Yeah.
And
so we've talked about bacteria, we talked about viruses, but sometimes people go to the doctor with symptoms that they think might be an infection, but it's not. It's actually a disease state. Something like chronic bronchitis. So chronic bronchitis is a condition where we have, some issues going on with the airway of the lungs, some inflammation and then some mucus and so forth. And a lot of the times, this chronic bronchitis, it's difficult to tell what's causing the infection or causing the process. Right. And we can divide these into acute and chronic bronchitis. Okay. Acute bronchitis is typically symptoms that have, been around for less than 30 days. And these are honestly usually caused by viruses, influenza, RSV, COVID, stuff like that, and not bacterial. Probably less than 5% of acute bronchitis is caused by bacteria. And then if we go to chronic bronchitis is really not infectious at all. That's caused by a structural problem, related to something like emphysema or chronic obstructive pulmonary disease or asthma. And, things like cigarette smoking, age, GERD or gastroesophageal reflux disease, these all cause those issues that related to the bronchitis. And if people just think, oh, I'm having trouble breathing, it must be an infection, you're missing the boat because the antibiotic's going to do nothing, waste the antibiotic, and you're not getting appropriate treatment,
right?
For things. Similarly, I mentioned pharyngitis, that acute pharyngitis. A lot of things cause sore throat besides bacteria and viruses. Dry air, chemicals, dust, allergies. All these things cause, a sore redness in the throat. Not going to respond to the antibiotics.
Yeah, and I think you bring up a good point, Mike. If we give somebody like that an antibiotic, we're not actually treating the problem that they have. So we're not doing our patients any justice.
So
in that way.
why don't we just diagnose them correctly?
They don't have time. And that's really it. There might not be a definitive diagnosis. I mean, there's not a lab test you run for, chronic bronchitis.
Sure.
It's an exclusionary thing that you maybe develop a case over time to, say that's the case. And unfortunately, if you're seeing the patient every, 8 to 10 minutes, you don't have a lot of that time, or you don't establish that care with the patient. And, with that, I think it's really important. We think about antibiotics and stuff like that being used for the infections. And, in medicine, we always think about risk factors. Mm-hmm. What puts a patient at risk for doing something? Favorite quote from a paper: the primary risk factor for a patient receiving an antibiotic is going to the doctor.
Well, yeah.
It's kind of like one of those, well, duh. But you think about it. And whether you go to the doctor with a fever and a respiratory condition or a cough caused by bronchitis, you're still going to the doctor. And if there's some uncertainty with making that diagnosis, the fact that you're there puts you at risk for coming away with an antibiotic, whether warranted or unwarranted.
Well, and I think, and this is really has only a little bit of what we're talking about to do with what we're talking about, but have you seen the advertisements recently for the antibiotic, what do they call them? Emergency kits? So they're selling these on the internet where you get a doctor's prescription and they send you a little cache of antibiotics to use in an emergency.
Where do you see this?
This being advertised on the internet. Now, I'm not going to give websites because I don't want people to use them. It's incredibly terrible.
Yeah, that seems
I'm not even sure it's legal, but so that's starting a thing.
Oh, don't even get me going on stuff like that.
So maybe you don't even have to go to the doctor.
I need to take a breath here after hearing nonsense like that. So why don't we hear from the Healthy Minute?
All right, let's pause for the Healthy Minute, brought to you by the winery at Young Farms. Today's Healthy Minute is clean your medicine cabinet. Our medicine cabinets are home to various medications, supplements, and personal care items, and it's essential to keep them organized and up to date. Removing expired or unused medications reduces the risk of accidental ingestion and ensures that the medications we have on hand are safe and effective when needed. A tidy medicine cabinet makes it easier to find what you need, especially in urgent situations. Quick access to essential items can be crucial in emergencies. When discarding expired or unneeded medications, do so appropriately to prevent environmental contamination. Many pharmacies and police stations have drug take-back boxes that are free for public use. Take a few minutes today to go through your medicine cabinet, check expiration dates, and dispose of items you no longer need. It's a small but impactful step towards promoting a healthier and safer living environment. That was the Healthy Minute, brought to you by the Winery at Young Farms in Mecosta, Michigan. Please visit www.thewineryatyoungfarms.com for more information. Now, back to the Health Deli.
Boom, chicka, boom, healthy, 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 healthy. Mark, I'm not going to say that was a great Healthy Minute, but it was. I think it was great because, back in the day, do you know how we used to get rid of old and expired products?
Toilet.
Flush them.
Yeah.
And so the fact that there's this raised awareness that if you flush antibiotics or if you flush any, drugs down the toilet, that's bad for the environment. Mm-hmm. And so kudos to you for raising awareness for these drug take back things.
Yeah. I like to trout fish and I want trout there 20 years down the road. So.
Yeah.
That doesn't have a bunch of amoxicillin in it.
Right.
All right. Let's get back to this outpatient antibiotic stuff. Mm-hmm. And Ben, you're Mr. Stewardship. You're Mr. Inpatient. I'm going to have you use your antibiotics right.
Dr. Stewardship.
Sorry, Dr. Stewardship.
Mr. Stewardship's my dad.
So a lot of this stuff that you do, you focus on using the correct antibiotic and the correct dose for duration, all this stuff, once an infection's been diagnosed in a sick patient, correct?
Yep, that's pretty true. So a patient might come into the emergency department and they'll say, hey, you have a skin infection, and they'll start XYZ medication, and then retrospectively I can look at that and say, okay, that antibiotic might have been incorrect. Let's change to this other one. Let's change to this, here's a duration you guys can use. So essentially the diagnosing's already been done and I'm just looking back on it and kind of like making small corrections.
So what if I told you that would be a stupid way to do things in the outpatient setting with respect to stewardship?
I would be insulted, but I'd also agree with you because
okay. So just hear me out then. In the hospital, people are in there for a short period of time for a specific reason, and we have access to all these lab tests and stuff like that. Mm-hmm. Patients are sick, they're in the hospital.
It's a captive audience. We have a lot of information.
And it's also a biased audience because they're there when they're sick. Mm-hmm. When you're not sick, not in the hospital, you're running around in your baseline state of health, okay? And you spend probably about 90% of your life in your baseline state of health, all right?
Okay.
And it's when you deviate from that, that's when you start going, man, I'm not feeling good. I need to go see a doctor. And those are the instances then, whether for an infection or for whatever else, you might have the risk of being prescribed an antibiotic. So doesn't it seem more intuitive then, rather than being reactive to sick people, be proactive to keep people in that state of baseline health?
Yeah. The one thing that I picked up when you said there that I loved is the risk of being prescribed an antibiotic.
Well, and that's really it. Antibiotics are useful when used appropriately, but what we've seen so often, especially in the outpatient setting, is there's a lot of misuse, not needed in 30% of the patients. Use the wrong dose or the wrong drug or the wrong duration, probably in another 50 to 60% of individuals. So there's a lot of improvement. So keep the people away.
Yeah.
Keep them so they don't need that antibiotic.
Yeah. And I really liked how you put that, Mike. Like, in the outpatient setting, we can't be reactive because it's hard to go back and change things when the patient's gone, right? They're at home, they're living their life. And so how can we stop that in the first place? How can we be proactive? And I'm really interested to hear what your thoughts on how we can do that.
So the first thing that I think that we need to do from an outpatient stewardship perspective is promote our patients to adopt healthy lifestyles. And this seems really weird coming from a sedentary dude who likes to eat really horribly.
Donuts.
But eating well and exercising can have just an incredible impact on your overall state of health and play a role in affecting your risk for needing to get an antibiotic.
I'm on a diet right now.
Yeah, what is that?
No, I really am.
Yeah.
I really am.
Yeah?
I am.
Oh, yeah. What are you eating?
I'm eating really good. I'm counting my calories. I've lost 13 pounds already.
Where'd you put it?
Well, I don't know.
You lost it.
You picked it up.
Anyway,
looks like.
of course I did. Oh, man. So, bringing this back. According to the Harvard T.H. Chan School of Public Health, your diet can influence your health in a number of ways. Obviously, malnutrition or a diet lacking in nutrients is bad, and that we know that can impair your production of the building blocks that you need to produce immune cells and antibodies. Also, obesity is bad. Not just, probably not what you think, but apparently obesity is associated with low grade and chronic inflammation. And the fat tissue produces these adipose cytokines, which are these inflammatory, things that create inflammation or promote the process. And obesity has been identified as an independent risk factor for acquiring certain infections, like influenza, possibly due to the impairment of some of your immune system components like T cells and, stuff like that. So there's more going on there with obesity than meets the eye.
Yeah, that's really interesting because I've heard that before, that being obese puts you at risk for these things, but I never really knew why. So,
Yeah. So, it's just a lot to unpack there that we might have to do later. Another thing is alcohol. Alcohol also impairs and suppresses the activity of normal immune function, and so that can increase your risk. And then ultra-processed foods. I mean, we're all, if it comes in a can or a box, it's probably been over-processed. But these can negatively affect your immune system as well. And the Western diet that's high in refined sugars and red meat and low in fruits and vegetables promotes disturbances in your healthy intestinal microorganisms.
Yeah, probably just the amount of preservatives we're in.
Yeah, just a whole lot of
Yeah, a lot
stuff.
of
And it
salt.
results, again, chronic inflammation of the gut, resulting in suppressed immunity. So we talk sometimes about the microbiome and stuff going on in your stomach. Again, another thing that we probably need to unpack a little bit all on its own.
Yeah. So when you say ultra processed, Mike, like what exactly do you mean? Do you mean like anything that's canned or
Well,
like
something that's highly refined. So it's, if you take a natural product like a grain and you crush it or whatever, you've got all the macro and micronutrients in there, but sometimes you refine it so much that you take out some of the nutritional value that's associated with the food.
Gotcha.
Like white bread and white rice.
Yeah, those can be, ultra processed as well. And that's why sometimes you have to supplement foods. That's why your milk is supplemented with vitamin D and stuff like that, because they found it as a great way to stick things in, or enriched bread and stuff like that.
I only eat or drink oat milk, because it's the goat milk.
Goat or oat?
Oat,
Oh,
because it's the goat, the
sure,
greatest
it's
of all
the
time.
greatest of all time.
Ben?
I thought we stumbled upon something else that Mark didn't know about.
Yeah.
No, I knew
Good
that.
job, good job.
I had to look it up a month ago, but I do know that. Yeah, the goat.
All
Greatest
right.
of all time.
All right. Anyway,
deep breath. So I mentioned nutrients are important, and one of you guys had mentioned supplements earlier. Now, although supplements really have not been identified to, avoid illnesses or whatnot, there are certain things like vitamin C, vitamin D, zinc, selenium, iron, and different proteins like amino acid and glutamine that are found in plant and animal foods that are important for your diet and important for you to be able to mount a good immune response.
Okay.
And so
And those
eating
are all
well.
found in a well-balanced diet, right?
Exactly.
Okay.
Follow the healthy plate and stuff, and you should be good. Okay. So that's eating well. It can have a significant impact. Then also exercise. Exercise impacts your immune system in a number of ways as well. First, it helps with your weight and can help you control a number of your diseases like diabetes, hypertension, high cholesterol, and so forth. And these are all things that people can have flare-ups of that might lead them to the doctor's office. If you don't have a flare-up, you don't go to the doctor, you might not get an antibiotic. Okay. And it's reducing, your likelihood of your obesity. So there was this paper in the Journal of Sports and Health Sciences by Neiman and colleagues that looked at a number of studies. This is one of the kind of like those meta-analyses things, Ben, that you talked about.
And so those are like really high quality papers for the most part, right?
Yeah, sometimes they can. If you do large studies with large quality study, yes. So let's say that this is good data.
Okay.
All right.
I'll assume that you did the evaluation.
Yeah, well, let's not go that far. But I believe these to be, solid findings. And they found that acute exercise is an immune adjuvant. It can actually improve your defenses and activity and improve your metabolic health. So it can kind of like stimulate your immune system.
Okay.
However, there is an inverse relationship between moderate exercise and illness and risk. That if you start exercising too much, you actually can impair your immune system. So those that are marathon runners and stuff like that can actually be at increased risk for a variety of diseases.
Interesting.
Yeah. So
I would never guess that.
It is very interesting. I actually, we won't get too much into it, but yes, doing like constant marathon running is actually can be bad for your body. Like our bodies were not designed to do that much,
Yeah, and that's why I
intensive physical activity. That's why.
Yeah.
Yeah, but it just makes sense. I mean,
Yep.
you run 26 miles every month.
Yeah,
I mean,
it's just, it's not going to be good.
Right.
The other thing exercise can do is it has an anti-inflammatory influence that's mediated through a number of pathways. So there's this whole bunch of things that, when you exercise, can occur. And randomized clinical controls, are consistent in demonstrating that participants that did moderate exercise had reduced upper respiratory tract infections and in shortened duration of those infections. And the magnitude of the reduction of the symptoms was greatest when there was near daily moderate exercise, and it reduced risk probably about 40 to 50%.
Okay.
So that's really quite significant.
Yeah. And so when you say moderate exercise, isn't it what, like 90 minutes of cardio or something along those lines? Is that what you're referring to?
Dude, I don't even get light exercise. So moderate, honestly, if you can get more than 30 minutes of exercise a day, I think you're in a good place for a lot of these, effects without being too taxing. But please always consult with your healthcare professional before starting a new exercise plan to make sure it's right for you.
Yeah, that's fair.
And so the literature definitely supports that exercise can help you stay healthy and avoid antibiotic use.
Yeah, that's interesting. I knew about the weight thing, but I actually didn't know that exercise by itself can help prevent things like infections. Pretty cool.
So again, rather than being reactive, we can be proactive to help reduce our need for antibiotics. And again, it's not just keeping off the infection, but that overall state of health helps keeping your flare-ups, from getting worse, or your diabetes from getting worse. Or if you're being adherent to your medications, let's say your inhalers for your lung disease, that's going to help you from getting lung flare-ups. If you get a lung flare-up, you might end up at the doctor's office. The doctor might, unfortunately say, oh, no, you need an antibiotic for that cough, when it could just be because you're not compliant with your medication. Or similarly with your diabetes. If you're not taking your medications as prescribed, you can be at increased risk. So now we got diet, exercise, and compliance being three really, really central things to keep you at your baseline health. And, I think those are things that we need to talk to our patient about. Also, simple things like vaccines. You know, we know that vaccines are not perfect. They don't 100% protect you from getting infections, but it does reduce your risk for that. So the less likely you are to be at risk, the less likely you are to go to the doctor, and so on and so forth. Also, wellness checks. Stay healthy. Know your numbers. Know your blood pressure. Know your A1C. Know your cholesterol.
Know your weight.
Know your weight. These are all things that are going to help you stay healthy, not be at increased risk for acquiring an infection, but also stay healthy and keep you away from the doctor, where again, that's your number one risk factor for getting an antibiotic, whether needed or not needed.
Yeah, and I'll just put a plug in for people that are a little bit younger in my generation, because I mean, like, I have no real like chronic comorbidities or chronic conditions, right? But it's still important every year to go to your physician to get, you know, your blood work done, to get checked up, make sure that you catch anything before it becomes a real problem, right? So even if you're feeling okay, it is still important to go like once a year just to make sure that you're doing all right.
Well, think about it almost like your investment account for retirement. You don't start saving for retirement when you're 75.
Right.
Okay. You start saving when you're younger, so you get that compound interest and the benefits over time. And that's the same thing with younger individuals. Unfortunately, they have this sense of I'm young, I'm healthy, I'm strong, and they do dumb things and they neglect their health. If you go into a room of individuals and say, you know, let's say younger people, and ask how many of you do not have a primary care provider or a doctor you go see regularly, data show that 30 to 40% of those people are going to raise their hands because they don't feel that they need a doctor. So they're not taking that medical precaution to keep themselves healthy.
Yeah, I think a lot of medical professionals are in that same boat where they're kind of self-treating, and you know the old saying that the doctor who treats himself as a fool for a patient is like true, right? You got to have that outside opinion. So healthcare professionals should be getting regular checkups and doing some of these preventative things as well.
Yeah, it's hard to be objective when you're looking at your own life, right?
Yeah.
Not for me.
Mike is
Purely
100%
objective.
Again,
I
I'm planning
am
the intervention.
Fabulous.
We're planting the seeds.
Sowing the seeds of love, as if it were. You know, so with that, you know, again, the way that we improve antibiotic use should be different. We should take a different strategy on the outpatient setting versus the inpatient. And right now in medicine, people are just trying to figure out how to rein in antibiotic use in the outpatient setting. And unfortunately, they want to try to do the same things that they're doing in the inpatient setting in the outpatient. And again, I think it's stupid because it's going to be a lot more effective to prevent antibiotics from being prescribed in the first place rather than reactively, you know, trying to manage those. So again, promoting healthy lifestyles, adherence with your medication, doing those wellness checks, getting immunized, those are probably some of the biggest things you can do to help avoid inappropriate antibiotic use in the outpatient setting.
Yep. And I'll just echo that because I've tried doing retroactive, kind of retrospective stewardship in the outpatient setting, and it is near impossible. So yes, we need a different way of looking at it. And I think what you're talking about, Mike, is a great place to start for sure.
Mark?
I agree. I don't want to agree with you, but I agree. I know.
Oh, I got this warm and fuzzy feeling that I have just... Mic drop.
I don't want. I know.
He's never had this warm and fuzzy feeling ever before.
I don't want to start exercising.
So, hey, Andrew, did you find out what pheochromocytoma is?
Yeah, it's a type of endocrine tumor that grows from cells called chromaffin cells.
So right there was an entire phrase that Andrew had troubles pronouncing. So this is going to be a great segment that we add. Can we just call it making fun of Andrew?
No.
Section? No?
We have to at least pretend like we're not doing it.
No.
Oh, okay.
What threw me off earlier is it has chromo in there, which I guess I don't fully understand. But in video production, we have chrominance. So I guess that's where my mind went with chroma. So I kind of spelled that correctly. But yeah, it was pretty easy to find. Google took my hodgepodge and...
But even though you have a definition in front of you, you still can't pronounce the word, nor do you really know what it means.
Neuroendocrine?
Yeah.
I think we should have the flip of this as well. I think Andrew should give us a word that he is
like a
familiar
technology
with.
word?
Yeah, that we have to.
I like
Now
that,
you're talking.
actually.
I think I could give words. Say custard-filled Long John. Everyone, best donut
White
ever.
cream filled
No,
Long
boo.
John.
White cream.
All right,
White
this
cream
is
flawed.
I wanted to end on a happy note, which didn't happen. So put the sign up and let's get out of here.
Thanks for stopping by the Health Deli to sample some of our wares. We're open 24/7 on Facebook and Twitter at The Health Deli, or visit thehealthdeli.com to send us a question or find any of our locations. Please come again. We will be regularly stocking the shelves with fresh content and new wellness specials. As always, we want to give a special thank you to Andrew Tingley and the crew at Ferris State University's Television and Digital Media Production Program. Until next time, so long from the Health Deli, where the topics are tasty, the takes are fresh, and the discussion is free.
We went right in the ditch.
What went in the ditch?
Best ending ever.
Went right
We
in the
went right in the ditch.
Yep.
Look, Natalie ran. She's like, no, I'm out of here. I don't want to be
She knew.
associated with this stuff.
She knew.
Oh, heavens.